Hey everyone, and welcome to The Explainer. If you're in medical training, you know that feeling. A patient says, "Doc, I'm dizzy," and your mind just explodes with possibilities. Well, today we're going to change that. We're going to break it all down with a really clear, high-value approach so you can walk into that room with total confidence. Let's get started.
And this quote right here, it just hits the nail on the head, doesn't it? Dizziness is so subjective. Patients might say they feel woozy or lightheaded or off balance, and it's our job to figure out what that really means. The stakes are high, and the path forward isn't always obvious. That's exactly the problem we're here to solve. So here's our game plan for today. We'll start with why this is such a challenge. Then we'll walk through a logical framework. How to classify dizziness, how to zoom in on vertigo, and how to use a key physical exam. Then we'll wrap up by mastering the most common cause. By the end, you're going to have a rock-solid approach. Okay, so what's the big deal with dizziness? Well, for one, it's incredibly common. We're talking millions of clinic visits every single year. But the real challenge? The list of what could be causing it is huge. It ranges from something simple in the inner ear all the way to a posterior circulation stroke. So yeah, it definitely keeps you on your toes. And this right here is the absolute key. While most cases of dizziness are not emergencies, you can never forget that it could be a stroke. Missing that diagnosis can be completely catastrophic. That's why having a systematic approach isn't just nice to have, it's absolutely essential. All right, so the very first thing we've got to do is take that vague complaint from the patient and give it some structure. And the most powerful way to do that is to classify their symptoms into one of 4 different categories. This is where taking a great history becomes your superpower. Think of it like this. You have 4 buckets. Is it vertigo, that true room is spinning sensation? Or is it pre-syncope, that feeling like you're about to black out? Maybe it's disequilibrium, where you just feel unsteady on your feet, kind of like you're walking on a boat. Or is it something more vague and nonspecific? Just by asking the right questions and putting their story into one of these buckets, you have already done most of the heavy lifting. So for the rest of our time together, we're going to zero in on that first bucket, vertigo. It's often the most dramatic presentation, and honestly, it's where the stakes for getting the diagnosis right are the highest. Now, when a patient has true vertigo, there is one fundamental question you have to answer. Is this a problem in the inner ear, what we call peripheral vertigo, or is it a problem in the brain itself, like the cerebellum or brainstem, which is central vertigo? It's the difference between a benign ear issue and a potentially life-threatening brain problem. So how do you tell them apart? Well, here are the big clues. Peripheral vertigo usually hits you like a ton of bricks, super sudden and intense, and it might come with ear symptoms like ringing or hearing loss. But crucially, it's usually just an isolated problem. Central vertigo, on the other hand, well, that's a brain problem, so it often brings friends along, other neurological signs. Think of the dangerous Ds: dysarthria, dysphagia, diplopia, trouble speaking, swallowing, or double vision. The eye movements, the nystagmus, are also a huge clue, and we're going to get into that next. And that leads us to the million-dollar question, right? Because here's the scary part. About 20% of strokes in the back of the brain present with only vertigo, without any of those other obvious red flags. So how can you be sure? Is there a way to figure this out at the bedside? You bet there is. Let me introduce you to your new best friend, the HINTS exam. This is a 3-part bedside test that, when you use it on a patient with continuous, ongoing vertigo, is an unbelievably powerful tool for telling the difference between a peripheral issue and a central stroke. Okay, let's break this down. First, the head impulse test. This checks the connection between the ear and the eyes. Now, here's the tricky part. If the inner ear is the problem, the eyes will drift and then snap back. We call that a catch-up saccade. And that's actually reassuring. A normal-looking test, where the eyes stay fixed, is actually the red flag for a central problem. Next, nystagmus. Peripheral nystagmus almost always beats in just one direction. But if you see it change direction when the patient looks left versus right, that's really concerning for a central cause. Finally, the test of skew. You cover one eye, then the other. If you see one eye drift vertically, that points right to the brainstem. Just remember, even one concerning finding here should make you think stroke. And here's why this is so important. Get this. In the first 24 to 48 hours, a fancy MRI can actually miss a small stroke in the posterior circulation. But a well-performed HINTS exam, it's often more sensitive. That is incredible. Mastering this physical exam skill can literally save a life. All right, now that we have a tool for the scariest cause of vertigo, let's switch gears and talk about the most common cause you're going to see and treat. And that's benign paroxysmal positional vertigo, or just BPVV.
you will absolutely see BPPV. The lifetime prevalence is around 2.4%, and what causes it is basically just simple mechanics. You've got these tiny little calcium crystals, otoconia, in your inner ear, and sometimes they get knocked loose and float into the wrong place. This causes these really brief, really intense episodes of spinning that are triggered by specific head movements, like rolling over in bed.
And you want to know the best part about BPV? You can often diagnose it and treat it right there at the bedside with a physical maneuver. No pills, no imaging needed. The treatment is called the Epley maneuver.
Let's walk through it. The whole thing actually starts with the diagnostic test, which is called the Dix-Hallpike maneuver. You're going to turn the patient's head about 45 degrees to the side you think is the problem. Then you quickly guide them backwards so they're lying down with their head hanging just off the edge of the bed. If that brings on their vertigo, and you see that classic nystagmus, boom, diagnosis confirmed.
Now, from that exact position, you move right into the treatment. You wait for the spinning to stop, and then you slowly and smoothly rotate their head 90 degrees toward the other side, the unaffected side. Just imagine you're using gravity to gently roll those little crystals out of the canal they're stuck in.
Next up, keeping their head in that same position relative to their body, you'll have them roll their entire body over onto their side. So now, they should be looking down toward the floor. This is just the next step in guiding those crystals back home where they belong. And for the final move, you slowly help the patient sit back up, all while keeping their head turned. This last movement lets the crystals fall out of the canal and back into the vestibule where they won't cause any more trouble. And just like that, you've often cured the patient's vertigo. It's amazing.
How well does it work? How about this? Up to 85% of patients are successfully treated with just one Epley maneuver. That is just incredible. This is seriously one of the most satisfying things you can do in all of medicine. It's high-value care at its absolute best.
Okay, so let's put it all together. Here are the key takeaways you need to remember for the next time you see a dizzy patient. All right, here's the bottom line. If the vertigo is brief and positional, think BPPV. Diagnose it with the Dix-Hallpike, no imaging, and treat it with the Epley. If the vertigo is acute and won't stop, that's when you have to think about stroke and use the HINTS exam. Never forget that about 1 in 5 of these strokes can show up with just vertigo. And at the end of the day, your most powerful, highest yield tools are always going to be your history and your exam skills. So, I'll leave you with this question. Dizziness doesn't have to be some diagnostic black box. With this framework, you can turn that vague complaint into a clear, confident, high-value clinical pathway. You've got the tools now. Thanks so much for joining us for this explainer.